Good morning, good evening, and good night from everyone across the globe that's joining us for this edition of the EIOC Journal Club. Today, we'll be talking about management of patients with AKT mutations post CDK4/6 inhibitors. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the United Arab Emirates, that is very sunny, very bright, and very, very safe for all of those of you who are inquiring about our safety here. So without further ado, I am joined today by some spectacular faculty, both internationally as well as local regionally, and I'm going to allow them to introduce themselves. So Carlos, please introduce yourself.
Hi, Shaheenah. Thank you for the invitation. My name is Carlos Barrios. I'm a medical oncologist devoted to breast cancer care in South Brazil.
Dima, please unmute yourself.
My name is Dima Jabbar. I'm one of the basically breast medical oncologists in UAE. I'm currently the director for Breast Center, Burj Abu Dhabi.
Sonia.
Hi, good evening, everyone. Dr. Sonia Otsmane. It's a pleasure to attend with you. I'm medical oncologist consultant in Burj Medical City. Thank you.
Dr. Hourani.
Hi, good evening, everyone. I'm Mohamed Hourani, medical oncologist in UAE in Tawam Hospital.
And Husam.
Oh, hello, everyone. I'm Husam Marashi. I'm a consultant medical oncologist from the east of the Emirates, Al Ain Tawam Hospital.
Well, without further ado, I'm going to share my slide. So let's replace the current slide. And I hope you can all see my slides. All right. So like I said, we're going to be talking mainly about patients with AKT mutations or alterations post-progression on CDK4/6 inhibitors. But let's take a step back and actually look at patients with hormone receptor positive, HER2 negative or HER2 low or ultra low disease, and what happens to them in the community. Well, they get several lines of endocrine therapy in that initial time of their treatment. And as you know, they move from an endocrine sensitive setting all the way to endocrine resistance and then to endocrine refractory setting. And at every time point, it's important to identify biomarkers because we know that biology changes and new targets can actually emerge. We've also have a lot of real world data sets that's actually showed us that when you go from first line therapy to second line therapy, you have a lot of the times you lose a lot of these patients going from first to second to third line therapy. And we also know that patients experiencing disease progression have a 52% probability of progressing to second line therapy within 2 years of actually commencing their therapy. Now, we have a lot of biomarkers that we look at in our community practice, and it's ever increasing. We always have to reestablish the ER/PR HER2 status of our patients at the time of recurrence or even at the time of progression of disease. The emergence of ESR1 mutations, that happens in about 40% of these patients. Looking at defects in the DNA repair pathways, of course, do not forget the alterations in the AKT pathway, which actually happens right from the very beginning in about 40% of our patients and associated usually with a poor prognostic outcome. And you should not forget those patients with other genomic alterations such as HER2 mutations, NTRK fusions, RET alterations, TMB high tumors. Again, if you do not test, you will not find. Sorry, my slides have gone backwards. So I'd like to ask the first question to Dr. Mohamed Hourani. Do you comprehensively profile your tumors to guide therapy in clinical practice in patients with hormone receptor positive, HER2 negative metastatic breast cancer?
So definitely in this group of the patient, especially the hormonal positive, it's very important looking for other molecular profile to guide us therapy. But the question here, when we are doing it, and in our practice, actually, we are doing it upon the first progressions comprehensively, except of the BRCA mutation, usually we are doing before, but the other molecular profile, we are doing it upon first progression.
And Husam, you're in the same institution. What do you do there?
Yeah, I think Dr. Hourani is right. I think that recently we were doing just on the following the first progression as the first line, what we call this remains the same for a long time, AI and CDK. But recently, I think the insurance approvals now becoming easier. So we're now able to do the tests easier than before. So now we started to learn more about these upfront mutations compared to the past. And of course, the germline BRCA and is there.
What sort of platforms are you using? Are you using like a limited gene platform or a comprehensive platform? What are you using?
So as I said, for those insurance allows, then we're able to send the NGS tissue now to M42. So that will be tissue NGS.
Okay.
Which is now, I think, almost the same for all Abu Dhabi. I think we have all access to the M42 Mubadala. So I think that's quite good to have. But also for some insurance group as well, we're able to do liquid if we want to do. But that's we keep it usually for after progression.
Okay, Carlos, in an ideal world, when would you profile? How often would you profile? And how comprehensively would you profile?
Well, I think that this is an important question, Shaheenah. This is an evolving practice we should all recognize. And as you clearly said, it's not only if you do it that I guess all of us should do it, but how often? That's the other question that you just asked. It is extremely important. I think that we need to recognize that we have changed our perception of breast cancer. Until a few years ago, 10 years or so ago, we were accustomed to treating all these patients as if we were all the same. And we used AIs, we used tamoxifen, we used fulvestrant, and we didn't have much in terms of endocrine therapy, maybe everolimus available for these patients. A long time ago, we used androgens to treat these patients as well, of high-dose estrogens, but those were the alternatives. Now we have become aware that these patients are different, and we have become aware of some of these differences. And the molecular alterations certainly are important in this group of patients. Theoretically, answering the question directly, we should try or we should consider looking for mutations at every progression, because theoretically the disease changes. The question basically is whether this information is going to change the way we are going to treat the patient. And so far, I think that, as my colleagues in the panel mentioned, after first-line progression, I think that there is where we have the evidence that is mandatory to actually test the patients. But in an ideal world, in an optimal world, probably learning how the disease evolves is something that we'll have to do in the future by testing the patients at each time the patient progresses.
All right. So once a patient, as we all know, in that first line setting, gets a CDK4/6 inhibitor plus endocrine therapy, this is the standard of care. It's based on multiple registrational clinical trials, phase 3 clinical trials. But post-progression, what is it that we do? There is this theory that you could potentially use a CDK4/6 inhibitor beyond progression of disease, and we certainly have a number of phase 2 clinical trials, as well as the post-MONARCH study, which is a phase 3 clinical trial that randomized patients post-progression on first-line CDK4/6 to either fulvestrant or fulvestrant plus abemaciclib. And you can see it met its primary endpoint of progression-free survival with an improvement of about 0.7 months, so modest. But that hazard ratio was 0.73. So again, some interesting data there. And it seemed to be mainly restricted. That benefit seemed to be mainly restricted amongst those patients who had endocrine sensitive disease. So those patients who took a long time to progress on first-line therapy compared to those patients who didn't take so long to progress on first-line therapy. So my question to you, Carlos, is do you use a CDK4/6 inhibitor beyond progression of disease, and if so, for whom? And the reason why I ask this question is not because of the post-MONARCH trial, But now we also have data from AMBER-3 that use CDK4/6 beyond progression of disease. We have data from ELEVATE that has used CDK4/6 inhibitor beyond progression of disease. And we have a lot of real-world data plus a number of phase 2 studies. So there is accumulating data that's telling us that we can potentially use this beyond progression of disease and have a better outcome. So where would you use it and for whom?
I think that's an important question. To tell you the truth, I'm looking at the data very critically. I have not been impressed with CDK6, 4 and 6 inhibitors beyond progression. I think that the pathway will continue to be important if you look at the biology of this for patients that progress. However, I have my own theory that needs to be proven. And that is that the cell cycle will actually reset itself after some time of using a CDK4/6 inhibitor. I have a hard time thinking that the resistance to these agents is actually definitive. So I believe that in some patients you actually can use the drugs beyond progressions. But I think that if you look at the mechanism of resistance, probably we will have patients that will benefit from this strategy of re-exposing cell cycle inhibitors later on with some treatment in between, with some time in between, to let the cell cycle to reset in that regard. What are the patients I would consider doing it now? I think that the patients that actually do not have any other mutations and that still do not have a very aggressive progression of disease. So in those cases, if I don't have any other alternatives, I think it's something that I would consider. But look at the data that you just presented. The numbers are not different from anything else that we have available today. So that's why I'm not that excited of using this kind of combination in second line.
I mean, Carlos, if I may ask the question, I think the biggest problem with the post-MONARCH trial was that it was comparing single-agent fulvestrant compared to fulvestrant plus abemaciclib. It answered the question, I think, that it's better to add something rather than nothing. But would it have not been better to actually compare abemaciclib fulvestrant to fulvestrant, say, and everolimus, or fulvestrant plus another biomarker combination?
Of course, you're raising a very important point here. As we change the perception on this disease, hormone receptor positive disease, I think that one of the emerging concepts everybody needs to recognize is that even there are some patients that can respond to single agents, as we have been doing for decades. I think that the rule in the future and the emerging information is that combinations seem to be a lot better. If you look at the Evera trial, actually shows very clearly that when you use in the control arm a combination, you get better results. So I think that that's a very good basis to change the way we look at the biology of these patients. I entirely agree with you.
So, Dima, what are your thoughts here? Do you use a CDK4/6 inhibitor beyond progression of disease? And if so, for whom? You're muted, Dima.
So I think it depends again on the biology and if I have anything else to target. So if I have nothing, I do the NGS panel and there is nothing else to target, and I feel the patient is still benefiting from CDK4/6, I might reuse it again. Yes, I've used it before. But I mean, if I have another target like the PIK3 or something else, I will definitely change the target. But yes, I've used it before.
Okay. So now coming to the Capitello trial, the Capitello 291 trial looked at patients with hormone receptor positive, HER2 negative metastatic breast cancer. These were patients who had either recurrence or progression while on or less than 12 months from the end of their adjuvant AI therapy, or progression while on an AI for metastatic breast cancer. They could have received less than or 2 equal lines of prior endocrine therapy in the metastatic setting, and at least they could receive at least 1 line of chemotherapy. Now, prior CDK4/6 inhibitors were allowed, and about 50% of these patients did receive a CDK4/6 inhibitor, no prior oral SERDs. and they had to have good glucose control. These patients were randomized, irrespective of the biomarker, to either capivasertib plus fulvestrant versus fulvestrant alone, and it had dual primary endpoints of PFS in that overall cohort, as well as in those patients with an alteration in that AKT pathway. Now, when you look at the outcomes in that dual primary endpoint, you can see in the overall population a very nice separation of the Kaplan-Meier curves, actually very early on, where the median PFS improves from 3.6 months to 7.2 months, hazard ratio 0.6, statistically significant, translating into a 40% reduction in the risk of progression of disease. And in that AKT altered pathway cohort, you can see the median PFS actually improves from 3.1 months to 7.3 months, a 50% reduction in the risk of progression of disease, and again, statistically significant. In an exploratory analysis, when you looked at those specific alterations, you can see it didn't matter if you had a PIK3CA alteration only, or an AKT alteration only, or a PTEN alteration only. Capivasertib actually worked in combination with fulvestrant, irrespective of the type of alteration. Now, I'm just going to go back to this, and Carlos, when I look at this and I see the approvals for capivasertib worldwide, it's very, very diverse. You have most countries that have followed the FDA approval of only allowing the combination in those patients with an AKT alteration, but it does work in the overall population. And I've seen some countries actually approve it beyond AKT alteration. What are your thoughts there? And then I see Husam nodding his head as well, so I'm going to ask him his thoughts there. Carlos.
Yeah, I will let Husam tell
First. Okay, Husam, you have
real,
first dibs on this.
the real story. Okay.
All right.
Husam, why don't you go ahead?
I feel strongly about this. I'm quite surprised that honestly the FDA did not let this go through. And I'll go back a little bit, step backwards. We have no data to use alpelisib and fulvestrant in the post-CDK up setting, and we're still allowed to use it regardless of toxicity, regardless of efficacy that's becoming far less. And with such data coming out with a drug that's far more tolerated, and there's still data for both of them, they only said allow it in the PIK3, what we call the AKT pathway, or maybe we should call it the PAM pathway nowadays. So to me, what you heard about this, so what I couldn't understand, I know there is some group, they said unknown, and they wanted to have more clarification about them because they said possibly there's not enough, we need more data about that group. But it seemed to be the efficacy for the combination is far better than Faslodex. I will look at this and say, whatever happens, I shouldn't prescribe Faslodex after CDK4/6 inhibitor. That's my feeling about it. I know the Canadian, Chinese allowed it, and I think we have this discussion before. So I'm sure Dr. Carlos have better explanation and better thoughts about this.
But before I allow Carlos to answer, I'd like to make the comment. I also have very strong opinions about this, but I disagree about the alpelisib part of it, because we do have data that tells us that we can use alpelisib beyond CDK4/6 inhibitor use.
Phase 3 randomized data that
it's not phase 3. It's not phase 3, but we don't need phase 3 nowadays. We have the data. We have the data. Hope Rugo presented that data. I will now let Carlos go to his comment. Carlos.
Well, first, addressing what you just discussed right now, the EPICS trial that was presented recently shows that in a population of patients with previous CDK4/6 inhibitor, alpelisib actually works, okay? And it gives you similar results to what we have. But certainly the toxicity of alpelisib is the remaining issue there that makes it clinically and in clinical practice not something very nice to consider. But looking at this data, that your original question, I think that there is something that Husam already mentioned, that there is a proportion of patients in this trial with unknown results. And there was a presentation by the FDA at San Antonio a couple of years ago, okay, that shows that the hint of the survival benefit or differences in further survival benefit is a little bit more clear in the AKT altered patient population than in the overall population. probably addressing this issue of the unknowns. So the FDA based their decision basically on that lack of information. Okay, so Australia and some other places in the world have approved an overall benefit. Looked at this as an overall benefit. I would personally be a little bit more conservative here. I would tend to use it in the mutated patients until we have some more data in the overall population. Having said that, there are some PI3 kinase drugs that are a little bit more complex than capivasertib that have shown benefit in the overall population, as in the Victoria trial. So I think that we should keep an open mind on this. But at the present time, my position is to look for the PI3 kinase, AKT, and PTEN mutated patients to consider capivasertib.
All right. So
the
yes.
mTOR, the everolimus is still approved for us after CDK4/6 inhibitor, and you can still say that it's far less effective and more toxic.
Okay.
Yes.
All right. That is Husam's stand on that. Dr. Mohamed Hourani, let me ask you a different question. Look at those different alterations. Would you have, for example, if a patient had a PTEN alteration alone, would you be comfortable giving capi versus if the patient had a PIK3CA alteration alone? You're muted, doctor. You need to unmute yourself. Yes.
Yes, Dr. Shaheenah. So I believe any alterations in the AKT pathway, regardless, showed benefits in the subgroups. Still, there is alterations between it, but all of them have efficacy in using capivasertib. So I believe I still will use it even if it's PTEN alone.
Okay. And Sonia, what are your thoughts over here? Does the type of alteration actually influence your decision? Is she here? Because I can't see her. Maybe she's not here. All right. So now let's go to the ESMO update of the Capitello 291 study. This was a very interesting analysis, I thought, in which they subdivided patients according to whether they'd received prior chemotherapy or not, or whether they had received it in the first-line therapy or not. So I thought this was a very, very interesting Kaplan-Meier curves. You can see the progression-free survival in the chemotherapy naive first-line endocrine therapy patients with alterations, and I'm assuming that these 32 patients had simply recurred early, and you can see their progression-free survival actually improved from 3.7 months to 14.3 months. Carlos, is this reflective of what we saw in the INAVO study? That, you have these chemo-naive patients, 32 patients, first line.
Yeah, and this points to the Capitello 292 that is addressing specifically that harder to treat, more aggressive patient population. So what my take on this information is that when you use this, that this is an effective regimen, okay? And when you use it earlier, you have a fantastic result. If you look at 14.3 versus 3.7 for fulvestrant, I think that this is an impressive result, taking the fact that there's a small number of patients, a sub-analysis, et cetera, et cetera. But certainly for me, it tells me that this is an effective regimen, particularly if you use it earlier.
And Dr. Dima, what are your thoughts over here, looking at this data? You're muted.
You can hear me now, right?
Yes, I can hear you now.
Yes, I definitely agree with Dr. Carlos. I mean, definitely, if I have the mutation, I would use this medication earlier if I can, especially if they don't do very well with the other hormonal therapy. So I agree with him.
Okay, so let's go on to the next slide. And then we have a lot of real-world data on the use of capi plus fulvestrant. And you can see, sorry, I have to go back one slide. Okay, let's go back. And you can see that these were patients, 412 patients who had received capivasertib plus fulvestrant. About 6.2% had actually received it in the first-line setting, which was very interesting. Majority of these patients had actually received it in the second and third-line setting. And interestingly, when you look at the time at the time to progression of the of disease, you see that the best one that you have is actually in that first line setting, really telling us that the earlier you use this combo, the better it is for your patients. So, Dr. Mohammed, when do you actually target that AKT pathway in your clinic, in the community setting?
So exactly as Dr. Shaheenah you presented earlier, using the endocrine therapy will get better result, and for that we always, or my style is preferred to consume all the endocrine therapy before jumping to the ADC or to the chemotherapy, knowing that data showing the DBO4, DBO6 that there was no big difference in using ADC in third or second line compared to what we are seeing in the Capitello or in the Capisertib when we are using early line compared to other.
And Dr. Marashi, what are your thoughts over here?
Yeah, I completely agree. I think it's high time for precision medicine. If you have disease progression on the aromatase inhibitor alone, so that's in terms of inavolisib, or in terms of someone in the first line in ICDK, actually that the perfect timing for use it as early as possible. Because not, as you said, not only the data is impressive, the PFS2, the first PFS, the second PFS for Capitello was quite fantastic. So I think switch it off that pathway as early as possible is going to be as rewarding as possible.
I have a comment, Shaheenah, if I may.
Yes,
I think
yes.
that, as we mentioned before, the combinations are better. Okay,
Always.
the 292 study is actually looking at a triple combination after what the INAVO 120 trial showed. So if you pick up a group of patients that is with a PI3 kinase pathway mutation, and at the same time the molecular alteration and a clinical performance of an aggressive disease with early progression within the disease course, this group of patients actually do better with a triple combination compared to a double combination. Okay, so again, with the concept that this is a complex biology, from the biology point of view, a complex disease that requires and will benefit from more agents. Okay, so I think that this is important information for everybody to recognize.
So Carlos, since you're on the podium right now, may I ask you the question, when do you actually test for alteration in the AKT pathway in a patient with metastatic breast cancer? When do you test, and when do you recommend that testing actually happens?
Well, in clinical practice at the present time, if I have a patient with early progression, we're still not testing because we do not have inavolisib ready for use in that setting. But that's the only reason. I would like to test these patients just to know whether the patient has that particular biology that could benefit from that treatment. But we don't have the treatment available here. So having the treatment available is important in order to define the testing frequency. Specifically, as I mentioned before, it's mandatory for everybody to test after first-line therapy. So I think that that's where everybody should be doing. My prediction is that as time goes by, testing will become cheaper, and we will be doing that much more frequently during the clinical course of metastatic hormone receptor positive patients.
So Carlos, if I may ask you another question, say suppose you have a clinical scenario where inavolisib is not available, because in a lot of countries it's still not available, it's too expensive as well. A patient, say a 34-year-old lady, stage 3 breast cancer, finishes everything, is on adjuvant endocrine therapy, no CDK4/6 inhibitor, recurs within 6 months of starting her adjuvant endocrine therapy, and is found to have a PIK3CA mutation. What are you going to give this woman? Are you going to give her Capi plus fulvestrant, because you do have the Capitello 291 that's telling you can, or are you going to give her a CDK4/6 inhibitor plus endocrine therapy with fulvestrant? Because you're in that situation now where this woman has relapsed within 6 months and is young, has a PIK3CA mutation, you don't have inavolisib. What are you going to do?
Well, I think that's a difficult question. I think that the data from INAVO 120 actually is really impactful in clinical practice. So I would be tempted to attempt a triple combination, but nobody's going to let me do that from the regulatory point of view here. So the alternatives you have in these early progressors, and it's something that we need to consider, is whether to use an ADC or a chemotherapy for this kind of group of patients, particularly if they are progressing very
if the
quickly.
burden of disease is low, why would you use chemotherapy without targeting that AKT pathway?
Well, my take on this, Shaheenah, is very practical. If a patient requires chemotherapy, okay, that doesn't mean that the patient doesn't have cells that will respond to endocrine therapy later on. So I may actually use the chemotherapy early, okay, or an ADC early. And if the patient develops a stable disease and the disease is under control, I may stop that treatment and treat her with endocrine therapy. That's a strategy that looks at the sequencing of treatments that we have not been able to study appropriately, okay? So I think that my take is that if I'm worried about that early progressor, 6 months, independent of the volume of disease, okay, I would try to use, okay, the best possible treatment, maybe an ADC, maybe chemotherapy, and then after a while consider endocrine therapy again.
Would you consider giving capi plus fulvestrant with close observation or close monitoring?
Yes, certainly. That's a possibility. If the patient has a target, why not?
That's what I was saying. This lady has a PIK3CA
Yes,
mutation.
sure. If the patient has a target, I think that's a reasonable alternative. But I wouldn't forget, okay, the target is not going to go away. I may treat this patient with a short course, 6 months. We're doing that. We're proposing this as a trial, okay, using an ADC for the first 6, 8 months, and then going back to endocrine therapy.
We then saw some other results from the Capitello looking at the concordance between ctDNA and tissue in terms of testing. And you can see that, in fact, the concordance is really not that bad. It's actually, in my opinion, very, very good. And when you see a patient that has that's positive by ctDNA and tissue, and you also have those patients which are positive with tissue only. So I thought this was also very, very interesting in terms of the data. And when I'm looking at it, Carlos, would you not agree that we should be doing, if in an ideal world, we should be doing both ctDNA and tissue together?
Certainly.
But you can't. And you have tissue that is negative, I would certainly try a liquid. Or if I have a liquid that's negative, I would certainly try a tissue. What are your thoughts there?
The data that Nick presented that you're showing the slides is that when you just do one or the other, you miss 10% of the cases.
Exactly.
So that's the point. So you have the 10% that is positive just by ctDNA alone, and you have the 10% that is positive just by
tissue alone.
tissue. So I think that the point is that the ideal world, you need to test both.
And we do have, the reason for this would be the low shedding tumors that he also presented. That's why it is important to actually do both modalities if you've missed it on one modality. Sonia, what are your thoughts here? I see you came back on.
Yeah, sorry, I was just so for this, yes, definitely I will test both. This is how we do it in our clinical practice with the liquid and tissue biopsy, and it gives better results and more rational to be able to use the PIK3 inhibitor. Like for me, I have used the capivasertib for few patients, and one of them was one of the fantastic successful story. She responded 14 months on capivasertib, and that was not on second line, that was on the third line after eventually NHER2, because she was treated with anti-CDK4/6 hormonal therapy, and then give her NHER2 when she progressed because she has also brain mets. She didn't have a fantastic response on NHER2, while she has almost the double of PFS on the capivasertib plus fulvestrant. And currently she is only on Zeloda for almost 5 months also, with maintaining excellent response, although she has a very big burden of disease, Shaheenah. This is also the example who had the brain mets, lung mets, liver mets, and this patient had a fantastic response on CAPI and on fulvestrant. So not all the patients are the same. I think we need to tackle our treatments and patients by patients, and depend on the percentage also on the ctDNA of the PIK3 mutation or the AKT. So this is very important also to study.
Thank you. I actually have very definitive ideas about, the VAF on a liquid biopsy. I don't think that that should be our driver when we're trying to interpret and what to target. But having said that, another subgroup analysis from the Capitello trial actually looked at those patients who had an ESR1 co-mutation versus no ESR1 mutation. And you can see that irrespective of the presence of a co-mutation or not, the combination of CAPI plus fulvestrant worked, and it worked very, very well. So, Mohamed, how do you test for AKT alterations in your clinic? Is it by tissue? Is it by liquid? Is it a combo of both?
So we get to use before using the tissue most of the time, and then we had an available to do the blood, the DNA. But still in AKT pathway, I prefer honestly the tissue, and we have some incident, me and Dr. Marashi, that we have a false negative through the blood test where it come positive through the tissue. Knowing that this is not an acquired mutations and I don't require a new biopsy to do it, not like the ESR1. So still, for me, I prefer do the tissue.
All right, now moving over to the oral SERDs, we have the Emerald, Serena 2, and Amber 3 that tells us essentially that when you use single agent oral SERD therapy, the benefit is there compared to using standard of care endocrine therapy in a cohort of patients with an ESR1 mutation, but the benefit is modest at best. In effect, you can see this big drop in the Kaplan-Meier curves right at the top, which actually reflects patients who have truly endocrine refractory disease. And when you use a combination, as what you can see in the Amber 3, of imlunestrant plus abemaciclib compared to imlunestrant alone, that's where you're seeing the bigger, better PFS. And you can see the drop is there, but the drop is not as deep, I would say, compared to what you saw in the single agent oral SERD therapy. And then, as Carlos said, we have results from the Evera study that tells us that the combination of giredestrant plus everolimus is superior to standard of care endocrine therapy plus everolimus. And again, you're seeing that that drop in the Kaplan-Meier curves are not as deep as what we see in single agent oral. Yes.
Shaheenah, let me interrupt you. Can you put the Evera curves there again?
Yes.
I think that it's not refractory, endocrine refractory disease.
No, that's what I'm saying. It's not.
Yes, that's the point. So
Yes.
I think that the drop means that there are some patients that actually respond to endocrine therapies, but probably in combinations. Okay, so that's, I think, that the main message here. So if the patient does not require an ADC, okay, or a chemotherapy and has a stable clinical course progressing slowly, certainly endocrine therapy in combinations will be the answer. And this is very clear data that shows, comparing across trials, how you treat that 40% of patients that drop initially.
But I would also like to point out that yes, it overcomes that huge drop that we've seen with single agent oral SERD. The combination is definitely the way to go. But despite the combination, there are some patients who will still not respond.
Oh, definitely.
And those are the truly endocrine refractory patients that need to go straight into ADC. And that's the point I was trying to make.
Yeah.
So when do you test for an ESR1 mutation, and how, Dima, when do you test for an ESR1 mutation?
I think now we should start testing everybody, right? I mean, after first line. So normally, I mean, before all the new data, I used to test only at progression or near progression when I feel the patient has some changes or some elevated tumor markers with no PET scan changes. You know, when I smell there is a progression, that's what I used to check. But now I think with the new data, going to start to doing, I mean, I am doing it earlier, just that's what I'm doing nowadays.
Well, if you look at the ESR1 mutation, when you go from first line to second line to third line to fourth line, you can see that the percentage of patients who acquires an ESR1 mutation progressively increases. So I certainly, in a patient first line, would not test for an ESR1 mutation unless they've been, like the SERENA-6 protocol, at least 6 months on combination endocrine therapy. Now, this was a very interesting network meta-analysis that actually said, it was published earlier this year. I thought very interesting data that actually told us that in a cohort of patients with an alteration in their AKT pathway, it didn't matter what you used. You could use combination endocrine therapy targeting the AKT pathway or the ESR mutation pathway, and these patients actually do very, very well. Now, I'm going to ask you some questions. The recent data shared at the SABCS 2025 for Capitella 291 data with a median PFS of 7 months for the combo of Capi plus fulvestrant versus 5.5 months that you see in the Emerald. Does this help you choose in patients with co-mutations? Carlos, does this help you
I
at
think
all
that this
choose?
is an important question. We do not have definitive data in this group of patients. Most of the data comes from retrospective analysis of subgroup analysis of all these trials. I think this is an unmet need. And I think at the present time, I think that using combinations in this group of patients seems a reasonably comfortable strategy. And that's what I try to do.
Husam, based on the real-world data that showed efficacy for Capi even in later line settings and after everolimus, fulvestrant, and chemotherapy, how confident are you in re-challenging patients who didn't have a chance to receive Capi earlier to receive it now?
Yeah, I think Carlos hinted to that earlier, and it is an important question. I think never underestimate the power of endocrine treatment. I think sometimes we all get disappointed with chemotherapy or cytotoxic treatment, and whenever you switch to endocrine treatment, you get the result. I'm certainly reassured by what being presented. I know you put on the top that's on the Capitella 291 in San Antonio. The 7 months came for those who actually selected more for the second line. What I'm trying to say is still, in general, the earlier we use endocrine treatment, the better.
You're going to get patients. The idea behind this question is you're going to get patients
stabilize them.
who come to you after several lines but never used Capi. Would you mind using it in later lines of therapy?
I don't want to sound that old, but Dr. Carlos will remember. We used to, number of people, we used to think that we exhausted all the treatment, and all of a sudden you give them tamoxifen, ask them to go away. And then 3 months later, after all these treatment, they come back and are symptoms better. With all the treatment, we can certainly have more sensitivity to endocrine treatment. So I wouldn't leave it to the end, but certainly if I have a chance when the patient is there ready for the capivasertib with endocrine treatment, I'll go for it.
I'm gonna review the recording of this meeting because I think that at the beginning of his last statement, Husam just called me old.
Okay.
No, me. I would say
I'm gonna review it before I say anything else, just to make sure.
So Carlos, if I can get back to you and your age that Husam has put forward here, what concerns might you have that may limit the use of capivasertib?
Well, the toxicity associated with capivasertib is less than the toxicity that we have seen with other PI3 kinase inhibitors, particularly alpelisib. But there's still concerns about patients that may have overweight or that are diabetics, where the toxicity associated, the hyperglycemia associated with capivasertib, it's an important consideration, something we should pay attention to. So I think that that's, for me, looking clinically at the group of patients I have been treating, the most important concern. But I have not seen that much toxicity, at least in the reasonably small number of patients I have treated with capivasertib.
Okay. Now, Dima, based on the ctDNA analysis that Nick Turner actually presented at the San Antonio last year, if you had a patient that was tested negative for an alteration in the AKT pathway on tissue, Should you sorry, on liquid, should this patient be tested again using a tissue sample and vice versa, or would you be just happy with the fact that it's negative?
So I usually send both at the same time, tissue and liquid biopsy. That's what I do with most of my patients. So yes, I would consider testing.
Husam, are you doing both tissue and liquid at the same time?
I have to admit, I'm not doing this at present. I have to say, if I'm going to do it, I will know that 90% of the test of one of them will be wasted, because if I have negative completely on one thing, then I will send for the other one. You know, it's great if we live in a world of academia, or when the money is not a problem, then I would love to test them both. We used to do that on
But
days and
Dr. Husam, the company paying for this test.
But you're still spending money, okay? So I think that we should try to make the best use of the money and the resources. I agree. I think that if you have the time to do it, if the clinical course of your patient allows for that, I think that I agree with Husam. I would do the ctDNA, and if that is easier, and if that's negative, I will use the tissue.
All right.
Alternative, you can start by the tissue, and if it is negative, you have 10% of having the ctDNA positive, as Nick presented at San Antonio.
And if the money is not an issue, go for it.
Yeah, of course. Now, in the last 15 minutes, we have a couple of cases that we can go through. The first is a 36-year-old lady. She's married with 3 children at age 29. She was diagnosed with stage 2 breast cancer, ER/PR positive, HER2 low. She got chemo, surgery, radiation therapy, and she got Zoladex for 2 years and tamoxifen for 4 years. She stopped tamoxifen and she wanted to have a baby. 7 years post-diagnosis, she returns with severe back pain and hip pain. So she actually relapses 4, 5, 6, 1 year, 2 years post completion of her tamoxifen. PET CT shows extensive bone mets. She commences on a CDK4/6 AI plus ovarian function suppression, and she has a PFS of 24 months. A liquid biopsy reveals an ESR1 mutation. Carlos, what would you do here?
I think that this patient, being young, I think that only bone metastasis. I think that the possibility of treating her with further endocrine therapy should be a consideration. And using in that treatment a new SERD, if you have it available, is a reasonable
We
thing
have
to do.
elacestrant here. Would you give her elacestrant single agent because her PFS was 24
Certainly,
months?
we know that patients that have had a more prolonged response to previous CDK4/6 inhibitor tend to respond to single agent elacestrant or a SERD. But the point here is that I think that we have not tested the combinations in this kind of setting. And my take is that if they have 8 months with single agent SERD, you may have a longer control of the disease when you use a combination. So I think that that's
But
the
Carlos,
critical point.
if I may interrupt you, NCCN now allows us to use combination oral SERD with imlunestrant and abemaciclib. Would you consider that if it was
Well,
available without?
that's certainly. I definitely this patient needs a SERD because of the SR1 mutation. And what I was saying, you can use that. You have a 9 months, 8 months PFS with the data that we have. The question is whether using the combination you can increase that, and that comparison has not been made, as you know.
Okay, so now this lady not only had an ESR1 mutation, she had multiple ESR1 mutations. And we saw also from Emerald that the more ESR1 mutations you have, the less likely elacestrant is going to work. And this was the data that was presented, from Emerald, from Serena 2. And you can see that if you had one ESR1 mutation, PFS was 12.9 months. If you had more than one, it was 4.7 months. So, Husam, would you give this patient single agent elacestrant, knowing that she has 3 ESR1 mutations?
See, I used to do it. I have to admit, I think the subgroup analysis from the Emeralds allowed us to do this and show it's no problem. I understand CNET 2, but CNET 2 has more limitation. I'm very, very, very intrigued, and I'm keen to use the combination because it makes sense to me. I'm sold on the Elevate data came out or the Evera. That's my short answer. And
Okay,
the
so you would use combo. You would not use single
Yes.
agent is what you're trying to say. Now, this particular patient, it's the same patient, actually didn't have only an ESR1 mutation. She had 3 ESR1 mutation, and she also had a PIK3CA mutation. So, Carlos, I made it more difficult. She's got 3 ESR1 mutations. She's got a PIK3CA mutation. She's got PFS of 24 months.
Okay,
What
before I
are you
make my
going to use? And everything's available to you. You could use combo oral SERD with abemaciclib or whatever it is you want to use. You could use combo capi. What will you use and why?
my tendency here would use to be to use a PI3 kinase agent here, and capivasertib would be my choice in this kind of clinical setting.
Why?
Ideally, the combination something that has not been tested, the combination of a new SERD with PI3 kinase mutated
Well, we can't do
inhibitor.
that. We can't do that.
Yes,
We
I
have
know,
no
but
data right
that's
now.
that's what I'm saying. So, in the absence of that combination, I would tend to think that PI3 kinase mutation could be an important driver here. The issue is that when you look at the literature and comments from reviews, it says that when you have a very slow growing and a easy patient, et cetera, you may consider looking at the ESR1 mutation as more important. My tendency is to look at the PI3 kinase mutation in patients that have a little bit more visceral disease, which most of the patients in this setting actually have.
But
Okay.
Dr. Carlos, the thing is with the imlunestrant trial plus Abema, it did have a PFS of 12 months, which I don't think any of the PIK inhibitors reached.
But it was a different setting. If you
Yeah.
looked at Amber
November
3,
first
these were
line.
pure patients who had all progressed on a CDK4/6 inhibitor. In Capitello, it was a mixture of different lines of therapy, and also chemotherapy was allowed in these patients. So I don't think that we can compare the PFS of Capitello with the PFS of Amber 3 unless you had that pure group. Now, if you had that pure group, first line or second line, the PFSs are very similar. So I personally don't think that you can. Yes, go ahead,
Yeah, no,
Carlos.
that's what I think that this kind of setting is very challenging. And the critical biological question is this patient progressing because of the PI3 kinase mutation? We know it's a mechanism of resistance, or because of the ESR1 mutation. So I think that the idea here is that we need to run the trials. My take, without absolutely any questions, is that instead of using just a SERD, a single agent, my take is that combinations are going to be better. Okay, whether you want to use a CDK4/6 inhibitor and an immunolestrant as in EMBER, whether you want to use a combination looking at the PI3 kinase mutations, I think that is something that you need to take into account. And we don't have actually clinical data to suggest one is better than the other. Okay, retrospective analysis and different subgroups, et cetera, and as Shaheenah said, different criteria to enter the trial makes it difficult for us to make that decision. Although it's something that we need to make decisions in clinical practice, as you clearly know.
All
See,
right,
that
next
40%
case,
drop
because
is
we
very
only have
concerning.
5 minutes. This is a 35-year-old lady with stage 4 de novo breast cancer, liver mets, lung mets, bone mets. Her biopsy at the time of diagnosis is sent for profiling, and she's commenced on a CDK4/6 inhibitor, AI plus ovarian function suppression. PFS is 30 months. Now, her original profiling of the tissue showed that it was ER positive. She has a PIK3CA mutation. And you can see her PFS was 30 months. Would you even bother doing a liquid biopsy at this point, Carlos? knowing that she already has a PIK3CA mutation from baseline, because that's what most patients have? Or would you do a liquid biopsy?
Well, I think that here you are looking for an ESR1 mutation, okay? So if you do a liquid biopsy, that's the question that we have.
Yeah.
Probably this patient is not BRCA mutated, correct?
No, she's
So
not. She's negative.
that
Yes. And
so
she's
that's
HER2 negative, so
yeah.
ADC doesn't even come into play here.
Yeah, so I think that I wouldn't necessarily do a liquid biopsy if I would do a liquid biopsy looking for a ESR1 mutation.
So that's exactly what I did. I did do a liquid biopsy. I found an ESR1 mutation, and she had actually progressed in her liver and bone, and she's not in crisis. PFS is now 30 months. Mohammed, what would you do in this particular patient? PFS is 30 months. She has an ESR1 mutation. She has at baseline a PIK3CA mutation. So she has a co-mutation. She's not in visceral crisis. I can see Sonia smiling, so I'm going to ask her next. So I'm going to ask you first, Mohammed. What would you
Yeah.
do for this particular patient?
So she did well in CDK4/6 inhibitors, and now
PFS
she's
is 30
having,
months. Very well she did.
yeah, and she's having now co-mutations. So I believe both options can be available here, but the data and Capitello is showing better result in the co-mutations, and the patient
Well,
has
that's not
multiple.
entirely true. I have not shown you the results of AMBER-3, which also showed that if you use an oral SERD, in a patient with a co-mutation, it works. It works very well. I showed you even the network meta-analysis. So I disagree with you that an oral SERD works not as well as targeting the PIK3CA pathway. So
In combinations,
in combination.
So
AMBER-3 was
that's
combo. AMBER-3
okay.
was combo. AMBER-3 was,
Okay.
that's what I said. I said AMBER-3. So, Mohammed,
Yeah.
everything's available for you. Everything. Carlos
Yeah.
is getting jealous because everything's available for you. What would you use for this patient? She's got a PFS of 30 months. I give you three options. I want you to choose, right? PFS is 30 months. The patient, I'll make it easier. She has one ESR1 mutation, so she doesn't have multiple ESR1 mutations like the previous patient. She's got a PIK3CA mutation, low burden of disease, so visceral crisis is not a problem. I'm giving you three options. You're going to use an oral SERD by itself, like elacestrant, which we have data from Emerald PFS more than 18 months. These patients do very, very well. Or you're going to use Capitello, which is capivasertib plus fulvestrant. Or you're going to use an AMBER-3-like protocol, because here we can do whatever we want. We can use an oral SERD in combination with an mTOR inhibitor or a abemaciclib. What would you use, Mohammed, and tell me why?
So, from our experience and real practice, in this case, we are using Capitello, giving capivasertib along with fulvestrant, which this type of patient will do well on treating them with capivasertib.
So, Carlos, I'm giving you the same three options. Everything is available. Regulatory authorities is giving you full, leeway to do whatever you want, because that's what we can do here. What would you choose?
I would choose the Capitello regimen mainly because my take on using CDK4/6 inhibitor again implies that I think that the resistance may not necessarily be permanent. So giving something in between, but that's my own take on the biology of this cycling inhibitors in general. So I would use the Capitello with the perspective of having the possibility of using a combination later on.
Sonia, you have 10 seconds to tell me which option you're going to use. Single agent oral SERD, Capitello, or an AMBER-3 type protocol. Everything's available very quickly. I need you to tell me the answer.
Thank you. Easy, Capitello, and definitely Capitello.
Okay, Dima, what would you use?
I think I'm the only one here. I feel bad. I would use the AMBER-3. I'm sorry for the Capitello,
Okay,
but
why would you use AMBER-3? I think it's perfectly fine to give that answer. I'm
yeah,
just asking you,
the
why
thing
would you
is
use
not wrong.
AMBER-3?
You don't need to be sorry. It's not wrong.
Yes, it's not wrong. It's not
yeah,
wrong. So why
I
would you
feel
use
like
AMBER-3?
yeah, the thing is patient responded very well for 30 months, so I feel she's not acting the typical PIK3 pathway, plus the side effect, plus she's 35, right? So I would definitely try, I mean, the ESR. I mean, I feel she's still hormonal, and especially if the progression is not in a crisis, I would definitely think of CDK4/6 plus the ESR1
I think
inhibitor.
that is very reasonable. However, I disagree with the fact that just because she's still endocrine sensitive, she would not need a PIK3CA inhibitor because you're still giving, fulvestrant with that.
No, but we can
I
still
think
try
I
it
think
on a
your
third
arguments are
one.
good. I think AMBER-3 type protocol is perfectly reasonable. And Muhammad, no, I've asked Muhammad, sorry, Husam. Husam,
Shaheenah,
yes,
I-
yes,
so
yes,
do you
Dima.
think if I use the AMBER-3 and then patient progress, I cannot use the fulvestrant and PIK3?
If you use AMBER-3 and
And
then
then patient progress.
we have zero data to tell us that she would respond to Capitello. However, what I would do is that if that patient had a good run on AMBER-3 type protocol with low burden of disease, I would probably use Capitello after that if I decide to use AMBER-3 first. However, if that patient progressed very quickly, high burden of disease, I probably would go on to an ADC because I wouldn't feel that confident that this patient's disease would respond. However, I think it's the clinical situation. We have reached the top of the hour, but I cannot, so I can't share the rest of the cases, but I still need to ask Husam because he's the only one who did not give the answer of what he would choose and why.
So
Very
you
quickly,
give
Husam, we
me,
have 1 minute. You have
you
one
gave us
minute.
all the option. I believe Capitello, capivasertib is the best drug to target AKT pathway. But I would love if there is no issue with I've got everything
Yes,
with
yes.
CERT. I'll put it this way: the safety data is out, Elevate, showing that the combination CERT and capivasertib will be the way to go. If I don't have any option, I think I will possibly, if I'm going to vote, I think we have 50-50. We can go for CERT with combination or with the capivasertib combination. And the combination CERT and capivasertib is the winner. No doubt.
If we
So
have it.
basically,
If we have
Husam
it.
is being overly diplomatic. So thank you very much. I think we've had a very nice discussion. And we've come up with absolutely the fact that everyone's divided in terms of how they would treat patients with co-mutations. But that's the art of medicine. We have to individualize therapy for every patient. And I think in 2026, there's been an explosion of data giving our patients multiple choices. I think the key message today is don't forget to profile tumors of patients with metastatic breast cancer, hormone receptor positive, HER2 negative. There are options, there are targets, and there's a lot more to come. So thank you, Carlos. Thank you, Dima. Thank you, Mohammed. Thank you, Husam. And thank you, Sonia, for joining us for this edition of the EIOC Journal Club. I hope to see you again. Take care.
Thank you
Bye.
so much. Thanks, everyone.
Thank you.
Bye.
Pleasure.
Thank you.
Where is the door?